For those of you who have not met me through other Green Flower events, let me tell you just a little bit about me so you understand where I'm coming from and why I'm up here talking to you about this sort of thing. So I am a physician and a fairly traditionally trained physician at that. I went to Harvard College, I went to Harvard Medical School, and I trained in internal medicine at the Brigham and Women's Hospital in Boston. So you can imagine that makes me a pretty stuffy kind of guy. But I'm also kind of weird, so whatever. That all being said, I've spent the last 15 years doing emergency work, emergency medicine in the VA, and through that process learned an awful lot about the ravages of drugs and alcohol in this particularly deserving population. And one of the things that I came to realize over time was that I had seen so many of these veterans that were truly harmed by various substances and yet never seen anyone who was sick from cannabis. Sure, plenty of veterans came in with cannabis use disorder as a diagnosis, but I'd never seen anybody sick. So in 2012, when Massachusetts started considering that cannabis might be a valuable medicine, I said, I better think about this and learn something about it. So several years worth of research in this rather skeptical, if slightly odd physician, I emerged the other side being very convinced that cannabis is a wonderful medicine for a number of problems. It's certainly not a cure-all, but it has wide use and we should take advantage of this. And you know, in some ways, Max's introduction really got to the punchline here. We really want to talk about how to use this stuff effectively and really respect it just like we would any conventional medication. And dosing, both in terms of the number of milligrams that we ingest and also the frequency and timing of those ingestions, is really at the core of what we're talking about. So the key concept here is what I call the minimum effective dose. And this really isn't a novel concept. It really isn't a cannabis-specific concept. It is the kind of thing that we instinctively or unconsciously do in medicine with all of our medicines. That is to say, at some point you go, that there's a sweet spot during which you get the maximum benefit of any medicine, and above that amount you start to get no increased benefit, but increased risk and side effects. And obviously, living in that sweet spot is where we want to be. And it turns out that for most people and for most illnesses, the dose, that sweet spot, is much lower than what we typically think and that we certainly hear about when we learn about this sort of thing from cultural references or from our friends or even just from sort of personal experience. I'd like to point you at this moment to my website, inhalemd.com, where I have over 100 articles on this various subjects that you can take a look at, and I think that they will be helpful. I want to address many of the issues surrounding dosing, and a lot of that comes down to understanding the delivery mechanisms. And there are now a sort of a daunting array of ways that we can use cannabis, and not all of them are particularly good. Not all of them are particularly appropriate for sort of thoughtful, mindful medical use. Unlike myself, many of the cannabis healthcare providers out there don't take the time or are not providing enough guidance for patients in terms of how to use this stuff and when to use this stuff. And I often make the kind of joke, but it's not all that much of a joke, that if you went to the doctor for your blood pressure medicine and the doctor said, yup, you've got blood pressure problems, go get some medicine, you'd look at them like they had three heads, right? You'd be like, what kind of a quack is telling me to just go get some medicine? You say, what medicine? How much should I take? When do I take it? What should it do for me? And what are the side effects that I need to be aware of? And I don't see why we're treating cannabis in any different way, but we are. And this is part of what I am here to try and help you with, and also sort of nationally kind of, if you will, crusading to change so that we can get this information out to people in a more useful and responsible fashion. So some general guiding principles here. Less is more. All right, we want to find that sweet spot, and we want to stay in that sweet spot. The minimum effective dose. I'm going to say this over and over again. Hope I don't bore you with it. But really, we want to figure out what it is that's going to do well for us. And that we need to get there by getting there in a slow and careful fashion. The word that we use in medicine is titration. And basically, what that really means is that you start at a very low dose, perhaps a dose that's low enough that we really don't expect it to do much of anything. But the point is that we're getting used to the process of putting this substance into our body, and that's both, physiologically our body is getting used to this, but also we're getting used to the process of taking it. And then we're going to slowly, very incrementally increase that dose and possibly frequency to the point at which now we're starting to get into the useful range. And then we're going to note where that is, and we're going to stop, and that's going to become the therapeutic amount. And so we need to be mindful of this process, and we also need to be mindful of the things that are side effects that we need to either be able to address or we need to be able to back away from. So side effects with cannabis are generally fairly mild, which is one of the benefits of cannabis, but we need to be aware of them. So things like dry mouth requires that we hydrate, and we should be prepared in our cannabis use so that we can hydrate along the process. For medical patients, by and large, intoxication is a side effect. It's not what people are, generally speaking, looking for from their medicine. They're looking for relief of certain symptoms or problems, and that's sort of what we're going after. And in many instances, then the intoxication or high is really something that comes along with the benefit that we're seeking, but it's not the main event as it might be for somebody who is doing this for more recreational purposes. Additionally, we can have things like racing heart, some feelings of anxiety and paranoia, and lightheadedness. Lightheadedness is particularly an issue if we have somebody or you are somebody who is older and where stability is a problem. Obviously, we don't want to use cannabis to treat our one problem and then end up falling over and breaking a hip and creating another problem. So we really do need to be mindful of all of these issues as we move forward. We want to be a little practical about this. And as we know, cannabis contains many, many important medicinal compounds, and that we believe that these act together, and that every time we try to extract one or more of these things and put it in a bottle, we find that these kind of fail to do what it is that we expect. So we really want to be using some sort of a whole plant starting point. But we also need something by which we can measure the dosing, and so THC is kind of the big number. So we tend to say that THC is going to be the guide. It's not that we're focused entirely on the THC, but rather that we're just using that as a way of quantifying what's in this cannabis. And sometime in the future, we may very well be able to be more specific about all the other things, but at this point, most of those measurements just lead us to getting more confused, and we need, over time to move forward with that process of quantification and information dissemination. Right now, when we're talking about THC as our guide, we're really thinking about things in milligrams. And for oral medications, when we're talking about an edible or something like that, it should be properly labeled with a number of milligrams in a serving or a dose. And we have to be very, very careful that we're taking what we think we're taking. We all know the story of the New York Times writer who went to Colorado and ate an entire candy bar which was not necessarily an unreasonable thing. We generally eat an entire Hershey's bar, but this, unfortunately for her, was a medicated candy bar, and she was probably reasonably supposed to take a slice of it and ate the whole thing and felt very sick from it. So we want to avoid those sorts of situations. When we think about inhalation as a means of therapy, then we need to be talking about inhalations as a way of measuring dose. And the good news is that with a good inhaler, a vaporizer, we can get a fairly good estimate in milligrams of what one of those deep inhalations is. I call them puffs because that's sort of the word that we use in medicine, but basically in the cannabis world we might call it a hit or something like that. And because most human beings, there's some variation between gender, but most human beings have roughly the same lung capacity, we can get an estimate that we're really talking about 3 to 5 milligrams per puff. We can, in fact, get more specific about this if you have a vaporizer and you can fill it with a known amount of cannabis, of a known potency, and then over a period of a few days, you can use up the amount of cannabis in that vaporizer, recognizing that you can turn the machine on and off as you need it. You don't need to use it all in one sitting. So you go through until you've used it up, taking just a couple of puffs at a time, and then when it is spent, and you know that it's spent because you take a puff, and when you exhale, that no vapor comes out, that means that puff was a dud and it's time to change. But if you counted the number of puffs, then you can do the calculation, which is really simple. You take the weight of the cannabis in milligrams, and you multiply it by the percent THC in the cannabis that you started with, and you divide that by the number of puffs, and then that gives you the number of milligrams of THC in each puff. I want to talk now a little bit about strains, ratios, and terpenes. One of the things I want to do today is I want to tell you a number of things that, quite frankly, may come off as being a little heretical. But where I'm coming from with this is really an attempt to impart to you stuff that's based on scientific literature and my experience in treating hundreds and hundreds of patients who I'm sure are much like you, and not so much based on the lore or culture that has arisen around cannabis. And for that reason, some of the stuff that I say is a little bit at odds with stuff that I hear from other people in the industry. So, for example, for 95%, I would say, of my patients, strain type doesn't really matter very much. Now, that's not to say that people don't develop preferences or favorites among strain types, but that in fact, when we're thinking about medical outcomes, more so than the experience or more so than preference, that in those instances, I don't find patients reporting back to me that the strains matter a lot to their outcome. And we know that the whole dichotomy between sativa and indica is really not particularly predictive at all. And it has led us to things like measuring THC, CBD, and other cannabinoids as well as the terpenes. I know that there is growing interest in talking about various ratios of cannabinoids, and I think that that's absolutely where we need to go as we come to understand this more and more. But frankly speaking, there's really very little medical literature at this point that points to how do we interpret this stuff. So we finally got laboratories like Steep Hill where we can actually get measurements on particular strains of what their cannabinoid and terpenes numbers are, but the problem is it's very hard for us to know what to make of those. And at this point, I don't think that we have enough data, or really any good data, at the level of science and medical science to be able to give instructions on that basis. We certainly know that there is a lot of discussion around certain terpenes like pinene or limonene that are supposed to sort of make you more outgoing and possibly even, in certain circumstances, provoke anxiety, as opposed to things like myrcene and linalool, which are supposed to be relaxing and even soporific. But again, this is all very much based on people's observations, and I don't know that we can really make firm statements on this. And one of my little pet peeves is cannabis potency. I think that when we look around at the universe of the strains that are available, what we tend to see is that there's a lot of strains out there that have been bred to be super potent, that they have very, very high THC content, 25 to 30 to 35% THC. And I think that presents us with a number of problems. The first problem with that is that when the percentage of THC goes up, there's a tendency for the other cannabinoids in the entourage to get excluded. And it's our best understanding at this point that all of the cannabinoids that exist in our medicine exist and play a role, or at least may play a role. And so a lower THC strain is likely to present us with a more balanced composite of these important medications. And I think the other thing that's really important is that dosing is really important, as we've been talking about. And if you use a super potent cannabis, then one puff could be a vast number of milligrams, and it's very hard to dissect one puff into smaller increments. So that if we can use a medium potency material, that allows us the flexibility to discern whether our dose is 1 puff, 2 puff, 3 puff, or 4 without it being sort of all or nothing. And this is very important, particularly when we're talking about avoiding the side effects that we would like to avoid. Right about now, I'm showing a slide of a number of vaporizers. And I want to start to talk a little bit about the methods of ingestion. So the first method of ingestion that I think we're all fairly familiar with is inhalation. And often I say to my patients, I start talking about this with reference to smoking, not because I recommend it, because I really don't recommend smoking in most instances, but rather because we all sort of have some familiarity with that process. And smoking really is a subset of inhalation. And the other actor in this category would be vaporization. And I think that there are many reasons that vaporization is probably a better choice in terms of avoiding products of combustion, and also you being able to use temperature deliberately in a fashion that allows us to manipulate the cannabinoids that we're getting to best effect. But I think one of the important things that I hear out there is this idea that inhalation sort of has an instant onset. And that's not accurate. It is rapid, and it is important to understand that it's rapid. That's a serious advantage in certain cases, particularly when we need relief very quickly. But it is not instant, and the reason that understanding is important is because if you think it's going to be instant, it's very easy then for you to sort of have a bunch of puffs expecting it to sort of really kick in, and then you go, well, it hasn't kicked in, so let me keep doing this. And even over the course of 10 to 15 minutes, you can ingest 5 or 6 puffs worth of material when what you really needed was 1 or 2, and then it kicks in, and suddenly you're realizing that you overdid it. Now, we're all very familiar with the idea that cannabis overdose cannot kill you, and that's true. But death is not the only outcome to be concerned about, right? I'm glad it doesn't kill anybody. That's very important. But being miserable for 4 hours or 8 or 12 hours, if we're talking about an edible, is not much fun either. And I think as a practitioner, this is also very important because many of my patients who may be older or sicker are not used to this material, and so getting them in over their head at the beginning is a disaster, because ultimately that discomfort leads them to not want to do it again and cuts them out of a very beneficial therapy that would help them if we were able to get there in a slow and thoughtful manner as opposed to overdoing it. Other thing to know about inhalation is that it only has a moderate duration. And again, this is very helpful to us when we think about how to treat certain things. So inhaled cannabis lasts sort of 3 to 4 hours before it's sort of more or less worn off. Because of this advantage of rapid onset and moderate duration, I tend to recommend inhalation by vaporization as a starting point for most illnesses. There are, of course, exceptions. There are a few things in the inhalation category that I tend to tell patients that I think they should avoid. One of them is concentrates. And I'm sure that there are people out there whose eyes are rolling at the moment, but hear me out. I'm certain that there are circumstances under which concentrates can be helpful. But when you start to think about sort of the needs of the average patients and people who are likely to be presenting with medical complaints to the doctor, that's not the typical use case. Concentrates are, not surprisingly, highly concentrated. If we're talking about, a gram of shatter that's somewhere between 70 to 90% pure THC, you're looking at 700 to 900 milligrams of active ingredient. Most of my patients start out at sort of 5 to 10 milligrams, and maybe they advance to sort of 15 to 20, and most, and I'm just saying most, of my patients do well in that range. So when you start to talk about concentrates, it's very hard to control the dosing with that level of concentration aiming at such a low dose. The potency can very much exacerbate all of the side effects that we've talked about, and in particular the one that is intoxication. And from a sort of longer term doctorly perspective, I worry about the safety in long-term high-dose use of concentrates. One of the things that we understand, is that throughout our brain and the rest of our body, there are cannabinoid receptors, brilliantly labeled the CB receptors. And one of the things that happens in not just the cannabis systems, but all signaling pathways throughout our body is that when a very loud, if you will, or very strong signal is presented over a period of time, the receiving cells protect themselves by doing what's called downregulation. And what that means is basically, if you imagine that you've got a whole bunch of receptors out there waiting for this stuff to bind to them, but then they're being flooded, and there's all this sort of loud signaling going on, what the cells do is they say, well, this is way too much, so I'm going to stop making some of these receptors. I'm going to pull down the receptors that exist and reduce the ferocity of the incoming signal. But this, of course, may lead to complications with those receiving cells, in particular if you do not then continue to bathe them at the same level. You can then end up with withdrawal symptoms, and essentially what we've just described is the mechanism of dependence. So dependence on cannabis, generally speaking, is fairly mild and can be treated but with abstention. But the point is, from a medical point of view, we don't want to do tolerance breaks and that sort of thing. We want to be able to continue to treat the symptoms that we're treating with the minimum of side effects. So ultimately, not getting ourselves into this situation is the best way to maintain the therapeutic benefit. So that's one thing that I suggest that we avoid in most situations. And then I think that the other thing that people are attracted to that's not particularly helpful is some of these oil-based vaporizer pens. They look literally like a little pen, and you put them in your mouth and you draw through them, and they dose you with some cannabis. But The issues with those are twofold. One is that many of them, or all of them, are based around these concentrates, so it's very hard to know, particularly since these devices tend to be fairly unsophisticated, how much cannabis you're really getting. And then the other thing is, because cannabis concentrates tend to be solid or semi-solid, these oil-based pens use additives to thin the material so that they work in the vaporizer pen without gumming it up. And the chemicals that they use are usually one of three: propylene glycol, polyethylene glycol, or a chemical called diacetyl. And I don't want to belabor what each of these does, but suffice it to say they all do something different, and none of them are anything that you want to have in your body, from causing plastic formation in your lungs to being carcinogenic. So in general, these are things I think you should avoid. Now let's talk for a moment about orals. Certainly edibles are very fashionable at the moment, and many of my patients, particularly older folks, come to me with the idea that this is the place that they should start. And in many cases, I feel ultimately that that's not the case. As I mentioned, inhalation is usually where I'll start people for most illnesses. But oral agents do have some very different properties that make them different and usable in certain circumstances. So we all know that the time to onset of oral medication is longer. And the problem is that, in fact, it's not just longer, but it's variably longer. So we sort of say, well, they kick in around an hour. And sort of probably on average that's true, but the problem then is, even from within the same person, that can be 1 hour or 2 hours or 3 hours. I've even seen it kick in at 4 hours, which means that if you need immediate relief from something, that's certainly not where you want to head. And it's also very easy to overdo it because, you know, if you've waited 2 hours and nothing's really happened, then, you know, it's very easy to say, well, I'll just take some more. And then somewhere around 4 hours, you get hit by a freight train. And again, it won't kill you, but you're miserable. The other thing to know is that because when we take cannabis by mouth, its first visit after it's absorbed by our gut is to our liver, there's actually a chemical transformation that happens. So that when we inhale cannabis, the primary psychoactive ingredient, as we know, is called delta-9 THC. But when it passes through our liver, it gets changed by the enzymes there into what's called 11-hydroxy-THC. It's now a different chemical, and it behaves differently on our brain and the rest of our body, and also in the way and the speed with which it's eliminated from our body. So that, in fact, cannabis taken orally has a much longer action of duration, sort of roughly 8 to 12 hours. And again, that's something we can take advantage of. We also have to understand that oral preparations can be very variable. Even commercially made products have been shown by scientific study now to be kind of potentially all over the map. There was a study done some years ago in California, some years meaning 18 months to 24 months ago, where they basically went around to a bunch of shops and picked up sort of commercially available, pre-labeled baked goods, and went back and tested their potency. And what they found was anywhere between 0 THC and double what was on the label. And some of those labels were quite high to begin with. So the point is, we need to be cognizant of the fact that this can be very variable, and we also need to understand that those variable preparations were the ones that were done commercially with all of the equipment and expertise of commercial bakeries. So when we start to even think about doing this stuff at home, which comes up a lot, we have to be very aware that our batches of brownies may be all over the map, and we may be in for a bit of a surprise. When we start to think about the value of taking things orally, the prolonged duration, I think, is very helpful. In particular, this is helpful when we start to think about people with sort of continuous symptoms like pain, right? Somebody who's in pain 24/7, we really think about those people as needing some constant relief. And so if we can use dosing of an oral cannabis agent on a sort of twice a day basis to get a sort of nice steady baseline of coverage, then plus or minus with some inhaled stuff on top of that for what we call breakthrough pain, or pain that exceeds the control by the oral agents, then we've got a regimen that really can control this sort of pain on an ongoing basis. When I started treating patients, I was very uncomfortable with the idea of cannabis medicine in foodstuff. And I still have some significant qualms about that. Remember that most patients are older, and that they have all the same sorts of other illnesses that typical Americans do. So a lot of them have diabetes. Most of them on average are overweight. And so saying, yeah, sure, take 2 brownies and call me in the morning doesn't feel like good doctoring. And all of that extra calorie and sugar in their diet presents problems. And when we want to be holistic and think about the needs of the entire being, that we're forgetting about their diabetes or their obesity or just their general health status in favor of the cannabis brownies isn't really very thoughtful. So for a while I was trying to avoid them, but it turns out that that's complicated, because when you give the same amount of cannabis as an oil in a capsule, it turns out that it doesn't work very well. It turns out when you do the studies that capsule bioavailability, meaning the amount that gets into your system and is available for your body to use as medicine, is kind of lousy at about 30%. Whereas the same amount of stuff in an edible, and in the case of the study that I'm thinking about, the edible was simply putting it on top of a little cookie, that edible bioavailability was at 60%, which is actually sort of in range with most other medications absorption. So another way of looking at that is that the edible was 100% better than the capsules. I have no doubt that in our future we will figure out how to make capsules function better in terms of bioavailability, and that's a good thing, and I look forward to that day because it will undo some of the problems that we have with all of these extra brownies and such like that. But we're not there yet, and that's a matter of getting the technology to catch up with us. And so at the moment, my view on this is that edibles are more effective, but what we need to do is figure out the appropriate dose of medicine and find the smallest dose of foodstuff that we can use as a vehicle. Another thing that is out there that I talk to patients a lot about is tinctures. Tinctures get around some of the problem with the food stuff that we were just talking about, because most tinctures have very few, if any, calories in them. And that's a good thing. But there are some things about tinctures that I think are noteworthy, and one of them is that by and large they tend to be more expensive per dose. So that's something that has to factor into our thinking when we're treating patients. And then there's this other thing, which is that there's this great, dare I use the word, mythology that has grown up around using these tinctures sublingually, meaning under the tongue. And when we think about conventional pharmaceuticals, there are fairly few of them that are used sublingually because, in fact, most medicines are not absorbed well that way. And the data that I've seen suggests that cannabis is similarly not very well absorbed, if at all, sublingually. And the experience out there that talks about using this stuff sublingually on an anecdotal basis is complicated by the fact that nobody ever swishes with this stuff and then spits it out, right? You put it under your tongue and you might hold it there for a little while, and then what do? You swallow it. Well, where did that go? Well, in your stomach, and it's absorbed like any other orally ingested stuff. So those experiences are somewhat tainted in terms of real understanding. The way in which I tend to use tinctures then is as a liquid form of oral. And I find it very, very useful for microdosing. So if I have a patient who's particularly sensitive to cannabis or generally sensitive to medicines, then what I will do is use a tincture because I can get down to dosing it milligram for milligram. And so if I need to start somebody on a 2 milligram dose so that we can work up to something that is effective, this is a great option. Now what I found for a lot of patients is that it's quite difficult to take a dropper of a tincture and kind of blindly drop it into your mouth. And so what happens sometimes is you squirt too much in there, you don't know what you did, you swallow it, and kind of that train has left the station. So I've actually developed a slightly different protocol in which what I tell patients is get a cracker or a small little piece of bread and drop the drops onto that so that you can absolutely accurately count them. And if you mess up, you throw it away because it's not in you yet, right? You start over again. So you put down the 2, 3, 4 drops, and then because fat is good for the absorption of these sorts of things, I say, like, all right, put a little butter on top of that and then just eat it, you know? And you don't have to swish with it and gargle with it, just eat it. It's just Weird Al Yankovic moment there. And that's extraordinarily effective. Another product that I want to talk about that is going to sound heretical are topicals. Topicals are medications that are applied to the skin. There is some growing evidence in the dermatologic literature that cannabinoids applied to the skin can be very effective, particularly for immune-mediated illnesses like psoriasis and eczema and other sorts of, again, immune-mediated rashes. But those things are surface skin conditions. And where we see the industry at the moment in cannabis focusing is on dermatologic application of these cannabinoids with the intent of treating deeper structures or even systemic illness. And there's really no evidence whatsoever that the cannabinoids get into your skin, past your skin. And if you think about it from a physiologic role, our skin has a very important role. It is our largest organ, and its job is to keep us in and the world out. That's really what it's there for. And it's very good at doing that. And again, like I said with the sublinguals, there are very few medicines that are used by applying it to the skin. And you say immediately, well, there are some creams. Yes, there are. Typically, however, those are for treating skin conditions. And then there are patches. Some people will say, oh, what about the fentanyl patch? Okay, fentanyl patch and other patches like that are not effective simply by sticking that agent in a patch. They use commercial detergents. One is called DMSO, and you complex the medicine with these detergents in order to get the skin to allow the medicine through. Essentially what you're doing is you're roughing up the skin to make it more porous, and then the medicine can go through. On the other hand, that leads to these patches, commercially available, conventional medicine patches, often provoke local rashes at the site where you have applied it, and so if you need it, you end up applying it in different places to try and sort of rotate the affected area. But the bottom line is, again, when we're thinking about cannabis as a holistic and natural approach to medicine, one has to ask the question, why are we even going there? So for my patients, by and large, I say this is very expensive and I just don't see that there's a lot of value in it for you. Once we've started talking or thought about routes of administration and sort of dosing per dose, meaning at a session or per use, then we need to start thinking a little bit about the frequency with which we're going to use this. And for most illnesses, the good news is that once a day is very effective. This includes most of the immune-mediated illnesses like rheumatoid arthritis, Crohn's disease, ulcerative colitis, even irritable bowel syndrome. It also is effective for a lot of the mental health issues that we talk about, like treating anxiety and depression, insomnia, and also for many of the wellness indications of de-stressing, etc., like that. Again, using this stuff, particularly in the evening before bedtime, is extraordinarily effective, and particularly effective because with the cannabis we recognize that as a side effect we're going to have what I call an intoxication phase, right? Cannabis gets you high, and there's really very little escaping that, so it becomes an issue, as with any other conventional medication, of managing the side effects. And if we take our cannabis medicine around bedtime or in the evening, then we're winding down our day. Hopefully we don't have much in the way of responsibilities, and we can tolerate and even enjoy that intoxication. And then we go to bed, and it helps us sleep through the night. And in the morning, it's gone, and the intoxication, I should say, is gone. We awaken feeling refreshed and ready to go about our day, but the cannabinoids are still with us, doing their job over that entire day without our being intoxicated. I find that both fascinating and miraculous and wonderful. There are other illnesses that are less amenable to that sort of thing, things which we might call sort of acute and intermittent, like a headache onset or a panic attack, or sort of the breakthrough pain that we sort of talked about earlier, or even treatment of anorexia or poor appetite in the context of chemotherapy or other things like that. At that point, we really need to be talking about using this not sort of on a nightly basis, or not solely on a nightly basis, but really as you need it. And I think that that's an important distinction. And because of the ensuing intoxication phase, we need to be thoughtful and mindful of that intoxication and the risk-benefit of what the impact on our day is going to be like. It's probably not helpful to tell a parent who needs to pick their child up at the end of the school day at 2:30 or 3 or whatever it is, that if they get a headache at noon, they should just take a few hits on their inhaler, because that presents them with a real problem. And so we need to be thinking about how we're going to use that and what the impact on the realities of life are. For more continuous problems that we mentioned, like severe pain, ongoing anorexia, that sort of thing, again, we need to balance that ratio of benefit and intoxication. And in those cases, we may very well find that the intoxication issue is much less important because the things we're treating are so profound and so harmful. But in those cases, we're really, again, looking at a mixture of using an oral for sort of long-term routine coverage of the pain with the inhaled for breakthrough. And this brings us right back to the minimum effective dose, which is of course what we're looking for, which is the dose where it works and treats our problem at the lowest possible dose and doesn't exceed that and run into extra side effects that we don't need, including increasing our body's tolerance, and that frequency in this instance, frequency of use and dosing, is just as important as the actual number of milligrams that we're taking. Just to give you a few examples of starting points that I will use for different sorts of illnesses, when we're talking about anxiety and depression, typically I will start somebody with a range. So I will start them on inhaled cannabis through a vaporizer, with the idea being sort of 2 to 4 puffs. And by that, what I really mean is that I want them to start at 2 puffs. And again, the numbers there vary a little bit by the size and the age of the patient, and also their prior experience and familiarity with cannabis as a substance. But sort of just as a general guidepost, I want them to start at 2 puffs and see how it goes. and if 2 puffs isn't enough, then take a third puff and see over the next 10 to 15 minutes sort of what effect that has. And if that's not effective, then they can turn their vaporizer back on and do a 4th puff. And what I tell patients is if you've really gotten to 4 puffs and it isn't doing anything for you, at that point I want you to email me. Not because I'm not going to say, okay, we can go up from there, but rather because I think it's important to maintain communication, and that, you know, at this upper range of the advice that I've given is the time for us to reconvene and to consider the issues that may be at hand. Similarly, for insomnia, same kind of dosing, 2 to 4 puffs around bedtime. For immunologically mediated illnesses like Crohn's, ulcerative colitis, rheumatoid arthritis, same sort of idea, 2 to 4 puffs around bedtime, all very good starting points. For headaches and panic attacks, where we talked about doing it as needed, it's still sort of that 2 to 4 puffs. And I try to say, look, because the dose and frequency is important too, if this comes up to being needed more than just once a day, then again, I think we should be chatting about this and seeing if there are other things that can be brought into the picture. If we're talking about sort of mild pain, particularly in the evenings after somebody's come home from work, then it may be the same 2 to 4 puffs, but we might want to advance that to being sort of more like dinner time rather than bedtime. And then, as we talked about a moment or two ago, when we're thinking now more about really severe pain, then we're mixing the oral and the inhaled. And so we might start again with a very low dose at 5 to 10 milligrams orally, typically again in the evening as a place to start and see what the reaction is like. And then ultimately from there we may increase that dose, as well as ultimately end up with a morning dose as well as the evening dose, so that we're really getting kind of around the clock treatment and coverage. And then of course, if we need it for the breakthrough pain, we will then be talking about using the inhaler or vaporizer, which, again, I would start with that same 2 to 4 puff range. So here are the take-home points here. We're always looking for that minimum effective dose. We want to be in that sweet spot between it's not doing enough and doing too much and giving us side effects. And so we creep up on that, and then we can find out where that is when we use a strain and a methodology that allows us small increments. We also recognize that inhaled and oral cannabis behave differently, and so we can use those to appropriate and therapeutic benefit. Again, I believe, and I've seen with my patients, that strain type isn't wildly important to the medical outcome. I don't want to say that, again, that this has no effect, but that it is not sort of the main take-home message. That there is, unfortunately, a lot of misinformation out there, a lot of products that are being marketed because they can, more so than because they're effective, and I think that you need to kind of view all of these things with an eye towards dosing and frequency and a little bit of skepticism in terms of what they're promising and particularly when we're talking about some of the routes of delivery that I had talked about not being particularly effective or not particularly scientifically valid. And then sort of lastly, we really need to be mindful of how we're using this and why we're using it and what side effects we encounter, and to consider the timing of this and the safety of the timing in terms of what we need to accomplish with our day, so that we come up with a regimen that best fits our medical needs and provides us with the greatest benefit and safety. So that's really my take on it. Thank you all for listening.